Now, I would love to hear more of your thoughts on NIAGARA, which very exciting data that we first heard about at ESMO this past year. So you're going to be presenting some exciting data at ASCO. Could you tell us more about some of the updates from NIAGARA and maybe remind us the trial design?
Absolutely. So Niagara, also the first in a series of studies integrating immune checkpoint blockade now into the neoadjuvant setting, or what's now referred to as the perioperative setting for muscle-invasive bladder cancer. So this study enrolled patients with clinically localized muscle-invasive bladder cancer. They were randomized to receive 4 cycles of Gem/Cis plus durvalumab, the PD-L1 inhibitor, followed by cystectomy, followed by 8 more cycles of durvalumab, or standard of care neoadjuvant Gem/Cis followed by cystectomy with no planned adjuvant treatment. Remember, when Niagara was designed, this was before the approvals of adjuvant immune checkpoint blockade. So that was the study design. We heard at ESMO, as you mentioned, the primary endpoint of event-free survival was met. And very interestingly, at the time of that initial readout, the secondary endpoint of overall survival already showed a significant benefit. And so really nice data, really hard to poke holes in the data, I would say, aside from the lack of adjuvant immune checkpoint blockade in the control arm, which of course was not a standard treatment at the time that the study was designed. Right. So that was the initial presentation. Toxicity data in this study, as you would expect, the addition of immune checkpoint blockade to cisplatin-based chemotherapy introduces immune-mediated side effects, but does not exacerbate chemotherapy-related side effects. And the side effects are not synergistic per se. So that was the initial data set. At ASCO GU, we saw the PathCR data from this study. And the take-home message there was that if you have a PathCR, you still benefit from the durvalumab. Right. And if you don't have a PathCR, you still benefit from the durvalumab. Right. So really the take-home message is that PathCR in and of itself is a useful measure. It's associated with prognosis, but it doesn't tell you exactly who's deriving all of the benefit from treatment. There, of course, are likely patients who have eradication of micrometastatic disease who have residual primary tumor who have still benefited from the systemic therapy. The data that are being presented at ASCO have to do with ctDNA. And this is probably the largest data set that we've seen so far with ctDNA in the neoadjuvant setting. We've seen a lot of adjuvant data. We haven't seen a lot of neoadjuvant data. The data involves the Signatera platform. And there's ctDNA was collected really at 3 key time points prior to initiation of any treatment, after neoadjuvant therapy, and then after cystectomy. And, you know, the high-level results of the study are that at every one of those time points, ctDNA is prognostic, as you might expect. Right. The second important take home is that there was a 10% higher rate of clearance of ctDNA on the neoadjuvant durva containing arm than the standard of care arm. And, you know, interestingly, that sort of lines up with the 10% improvement in PathCR rate with, so that was a key finding. If you have detectable ctDNA after neoadjuvant therapy on either arm before cystectomy, that's a very unfavorable prognostic indicator, as you might expect. And virtually no patient had a PathCR who had detectable ctDNA immediately prior to cystectomy. And then the last take-home point is that the rates of ctDNA detectability, as you probably might imagine, decrease consecutively during those 3 time points. And after getting neoadjuvant therapy and having a cystectomy, the rates of ctDNA detectability post-cystectomy are actually really low. And I think, you know, people are going to compare those rates to studies like IMvigor10, but you have to remember that IMvigor10 was biased towards patients with pathologically adverse, with adverse pathological features, whereas the data set includes all patients.
Right. Yeah, that's absolutely a great point. And that's really exciting data. How do you see ctDNA being integrated into the clinical workflow outside of trials? Are you using it right now for perioperative muscle-invasive bladder cancer?
So we're using it pretty routinely. I think the challenge is, aside from the lack of clinical utility right now, are that the tests based on tumor-informed testing don't come back when you have to make treatment decisions. And so the data in the baseline setting that we're going to show for Niagara, really in clinical practice, you wouldn't have that information in time to make a treatment decision. And so it's prognostic, it's informative, it adds to the conversation, it adds to shared decision making, I think, from a prognostic standpoint, because we're pretty confident with all the data that it's prognostic now. But whether or not ctDNA at any of these time points helps us make better treatment decisions, we don't know, because we don't have trials demonstrating clinical utility. Hopefully, IMvigor11 will do that. Hopefully, Modern will do that, and in other prospective studies.
Absolutely. And I know you're involved with Modern. Could you tell us more about Modern and how ctDNA is used in that context?
Yeah. So in Modern's an adjuvant study, and it's designed to really replicate Checkmate 274 and that generation of adjuvant studies, and that the pathological eligibility criteria are virtually the same. So patients, if they had neoadjuvant therapy, they have to have pathological T2 or higher disease in their surgical specimen. If they didn't have neoadjuvant chemotherapy, they have to have pathological T3 or higher disease in their surgical specimen and be cisplatin ineligible or cisplatin refusing. And then patients after surgery with those pathological features have ctDNA testing using Signatera. If they have detectable ctDNA, they're randomized to standard of care, 1 year of adjuvant nivolumab, or to escalation of treatment with the combination of adjuvant nivolumab plus adjuvant relatlimab, the LAG-3 inhibitor. If they have undetectable ctDNA, they're randomized to standard of care adjuvant nivolumab for a year, or to surveillance. And patients on surveillance have ctDNA serially monitored. And if that ctDNA converts to detectable, then they can initiate nivolumab at that point, with the hope that that will be a sufficient lead time to still provide cancer control, similarly to if all treatments got treatment right away after surgery.
Absolutely. I think that will definitely be helpful to know a more risk-adapted approach in the adjuvant setting. And as far as patients that did not achieve ctDNA clearance post-cystectomy, what are your thoughts? And were there any other factors in the updated analysis that suggest, predictive aspects of someone's tumor, or other factors that impacted ctDNA?
Yes. So ctDNA detectability after neoadjuvant chemotherapy followed by cystectomy, or neoadjuvant chemotherapy plus durva followed by cystectomy, ctDNA detectability, it's about 10% all comers after. So it's pretty low. But if you have detectable ctDNA in that context, as you can imagine, outcomes are very, very unfavorable. So we need to find a way of doing better for those patients without a doubt.
Right.
In terms of features predictive of shedding of ctDNA, probably the best work is still related to IMvigor10, where gene expression data was correlated with the likelihood of shedding, showing that some of the molecular features of tumors that are associated with shedding are what you might think of intuitively. Lots more EMT-related gene signatures, lots more activated stroma-related gene signatures.
Wonderful. And thank you for sharing all of those insights. Any final thoughts as far as Niagara, or the use of ctDNA in this space?
I would say that the field's moving really quickly. I think we're looking hopefully for a really big ESMO as well. So we're talking about ASCO, but ESMO's right around the corner. And I think it's going to be a big year for improvements in outcomes in bladder cancer that will hopefully translate to better lives for our patients.
Absolutely. I think it's a really exciting time to be in the bladder cancer world. And, perhaps we're going to have even more targeted approaches move into the perioperative space beyond what we have right now. So thank you for sharing all your insights. And I think it will also beg the challenge of immunotherapy rechallenge with all of the things that we're talking about moving into the earlier space.